It's my great pleasure to introduce Her Excellency Dr. Maryam Al-Hajeri, the Vice President of Bahrain Diabetes Society, to give her welcome remarks.
صبحكم الله بالخير. باسمي وبالنيابة عن معالي الفريق الشيخ محمد بن عبد الله آل خليفة، رئيس المجلس الأعلى للصحة ورئيس مجلس إدارة جمعية السكر البحرينية، نرحب بكم معنا في هذه الحلقة العلمية حول السكري والسمنة. هذه الحلقة الثانية وإن شاء الله بتكون هناك حلقة ثالثة. كل الشكر والتقدير لمشاركتكم معنا، وكل الشكر والتقدير للمحاضرين اليوم اللي بيكونوا معنا. طبعا مثل ما انتم عارفين السكري والسمنة صاروا عملة واحدة. السكري في ازدياد على مستوى مملكة البحرين وعلى مستوى الإقليم والعالم، وكذلك السمنة في ازدياد. يمكن دكتورة بثينة مشكورة عجلان رئيسة قسم التغذية بوزارة الصحة ستوضح لنا عن السمنة في البحرين وماذا تم عمله لمكافحة السمنة في البحرين. جمعية السكر البحرينية لديها حملة أو مبادرة هي مكافحة السمنة والسكري، بدأناها من كم سنة، ونفذنا كذلك حملة في المحافظة الجنوبية بالتعاون مع بابكو إنرجيز على مكافحة السمنة والسكري، وبدأناها من نوفمبر 2024، وإن شاء الله بنكون مستمرين في هذه الحملة لنهاية هذا الشهر. واكتشفنا العديد من يعني المشاركين الذين لديهم زيادة في الوزن والسمنة والسكري، وهذا من أهم أهداف الجمعية السكري، هي الاكتشاف المبكر عن هذه الأمراض. Ladies and gentlemen, on behalf of Bahrain Diabetes Society, I would like to welcome all of you on behalf of Bahrain Diabetes Society and Sheikh Mohammed bin Abdullah Al Khalifa, President of Bahrain Diabetes Society. As you know, diabetes and obesity, now it is increasing, not only in Kingdom of Bahrain, but all over the world. As you know, diabetes, even in the children, we're facing now a disaster, especially among the school children. We saw lots of children with type 2 diabetes because of overweight and obesity. So our meeting, inshallah, will tackle this point regarding obesity and children, and obesity and complication, and obesity in Bahrain. So again, I would like to thank all of you. مشكورين على حضوركم، وإن شاء الله تستفيدون من هذه الحلقة. شكرا.
So as you've heard from Dr. Maryam, this is cycle or wave 2 out of 3 waves that are focused on diabetes and obesity. And in Bahrain Diabetes Society, we are strong believers that if we want to make a meaningful impact in the future on the prevalence and the spread of type 2 diabetes, we have to tackle obesity as the biggest risk for developing diabetes in the future. So from that belief and enthusiasm about obesity management, we have released a book called Obesity in Bahrain, both in Arabic and in English. We've launched Bahrain Obesity Academy in 2021 and graduated clinicians on management of obesity from that program. And this is a continuation of that, in addition to Bahrain Diabetes and Obesity Conference that we've done last year. In the first wave, we spoke about obesity as a disease. It's no longer a risk factor. It is an established disease, so it needs proper investigations, proper diagnosis, prevention, and treatment. We spoke about management interventions in adults and in children. And in this cycle today, you will hear more about the initiatives and efforts about obesity in Bahrain through Dr. Buthaina Ajlan. Then you'll hear from Dr. Hamdan Neshmi about obesity stigma from a psychology and a psychiatrist perspective. You'll hear from Dr. Hassan Farroukh about complications of obesity, and then from Dr. Khadija Al-Ula, how to evaluate patients with obesity in pediatric clinics. So an inclusive program that is relevant for doctors, nurses, dietitians, educators, etc., in both fields of diabetes and obesity. Thank you to Lily for sponsoring this event without any intervention in the talks and the content that we present to you today. And there is a speaker on behalf of Lily, Dr. Wiam Hussein, who will talk to us about tirzepatide and type 2 diabetes and weight management. And at the end, we'll have closing remarks and then invite you to lunch around 12:30. So without further ado, it's my great pleasure to introduce our dear colleague, Dr. Buthaina Ajlan, Head of Nutrition Department in Public Health, Consultant in the Ministry of Health of Bahrain. She's a family medicine consultant in primary healthcare, and she's head of Breastfeeding Support and Monitoring Code of Marketing of Breast Milk Substitutes National Committee. And for me, I always learn something new, and it fills me with pride when I hear what she has to say, because it tells you how much Bahrain is doing in the Ministry of Health for tackling obesity on a national level. So thank you for joining us.
Thank you, Dr. Dalal. Good morning, everybody. I'm glad to be with you today, and I'm always excited to present our efforts regarding combat obesity in Bahrain. Inshallah, get a completed picture about what is happening in Bahrain. In my presentation, I will talk about the obesity regarding the challenge, regarding the current initiative and achievement to combat obesity. Plus, at the end, we'll see what is next, what is our goal until 2030, and how we will reach our goal. My presentation a little long, but I will go quick and fast. First, I will start my presentation with the acceleration plan. Bahrain proudly had chosen among 28 countries worldwide to be one of the front-runner country and to implement the acceleration plan to stop obesity. Maybe some of you heard about the acceleration plan released by WHO. Only 28 countries chosen, and from GCC, the Bahrain was the only country to implement the acceleration plan. What does mean front-runner country? Bahrain is a front-runner country, mean Bahrain had significant progress in different aspects regarding policy, initiative, project within the recommendation of WHO. We developed many successful stories regarding this area. This is what is mean front-runner country. We're happy to share this successful story with the world during the 76th World Health Assembly was in Geneva in 2023. Bahrain launched a side event. Within this side event, they were very interested to hear what Bahrain had do from policies, initiative, project to reach, to be considered as a front-runner country. And from this event, we launch our acceleration plan. And it is mentioned in Lancet, a scientific paper release, and there was recognition regarding the Bahrain effort. The challenge, all of you, I think, know the challenge. 42.5 female have obesity and 33% from the male. Based on the National Health Surveillance, we wish in the result for the current health surveillance to be better, inshallah. Regarding the adolescent, there is many published articles to mention that the prevalence of obesity and overweight among the children and adolescents, most of them have similar results, total of 42%. Again, other paper within the school screening program showed a total overweight and obesity 40-something%. Latest 2022, there is a paper studies the relation between vitamin D deficiency and obesity in adolescents in Bahrain from 11 to 19 here, shows 54.5 were obese, 16.5 were overweight. Regarding below 5 years, just 5.4 based on primary healthcare reports. We had just finished a surveillance among the school, private and government school, to measure the prevalence of overweight and obese in intermediate and high school students. Total sample of 1,880. This is the initial result, still not published, but it is a nutrition section report. Shows happy surprise that the prevalence of overweight and obesity reduced, as you see in this graph, sorry, in Arabic. The overweight is 19.7, 13.9, and the obesity 20.2 among the male, 8.8 among the female. In private school, the percentage little higher, 25, 19, 29, 19. If we compare the recent result with the previous result, you will see that, let's see the last graph, from 44, 42, total 39, male and female government and private school. Any decreased even 0.5, we will happy from it, because it means we are in the track. Regarding the current initiative and achievement, we have a lot of achievement and an initiative regarding combat obesity and NCD risk factor related to food intake. I will go quickly for the most important initiative. First of all, we have the political support. As you know, there is a national task force team chaired by Minister of Health and member from all of the related governmental authority and NGOs. All our project, initiative, policy pass through this committee, and all the members put their input regarding any new project until from the developing until the release. We have a national plan to prevent the obesity, and now the acceleration plan. Bahrain had covered all the aspects of related diet-related policies. We have policy in trans fat, reducing the salt, taxation, labeling. The green shows that Bahrain cover all the aspects except the front of package labeling. It is still under the study process. Our initiative, we make sure to be multi-sectorial and to cover all age group, from the early nutrition, adolescent school-based, NCD risk factor, awareness, education, surveillance, and research, plus the special nutrition for elderly, sport nutrition, and micronutrient. First, we'll go category by category. The first categories is the program for maternal, infant, young child nutrition. I cannot jump to the achievement without saying that Bahrain, one of the first country in 1995, have adopted the international code to control the marketing. We reinforced this law in 2018 by ministerial decree. Since then, the achievement have going on by form the committee. 100% all the food for infant and children from 0 to 3 years cannot enter Bahrain unless they studies and license. The violation in the market, maybe you notice there is no free samples marketing in the souk. Sorry for this error. And we, since 2019, we start a package of workshop of a 20-hour training for the doctor and nurses. Just now we were celebrating of 700 health workers had trained with a certified 24-hour breastfeeding counseling, accredited from Nahra. This is our celebration from 2019 up to 2024. Plus, we had finished our mock surveillance regarding the baby-friendly hospital. Just now in November, we trained 74 doctors and nurses regarding to be assessor for the hospital for the accreditation. After Ramadan, the process of accreditation to be all the hospital in Bahrain, baby-friendly hospital, will start from April, inshallah. Now we have a good, strong team of 41 doctors and nurses. As I said, we believe in education and awareness policy, initiative, project. Without sharing the community, it is difficult to be succeed. succeed. Because of this, we have الرضاعة أساس الحياة. It is a community-based campaign since 2018, launched officially 2020 with collaboration with the hospital, private and government and universities. Up to date, more than 1,800 beneficial from the campaign. In 2023, we transfer campaign to virtual. You can find it in the website of Ministry of Health and download it in your mobile. It will be available for any mother or nurses, doctor, with a full comprehensive information regarding breastfeeding. We encourage the workplace to open a breastfeeding room or mother care room. Many of workplace had developed this. Second, for a school-based nutrition program, we had good to know that Bahrain, there is a legislation regarding controlling the beverage and food in canteen, private and government, and the nutrition section yearly update and release guideline published in Ministry of Health website. This is our process, long process, include workshops, visiting the canteen, sitting with the food provider, visiting their kitchen. Now we can say from 108 violation in the field visit 2019, up to the last field visit 2024-25 covered all government school, the violation reduced significantly from 108 to 10. For the private school, join the program in recently in 2023. We start arranging the workshop, the meeting, visiting the canteen, sitting with the food provider. Inshallah, we'll share with you the same successful story in government. We wish to achieve it with the private school. The third category is initiative and project to reduce the risk factor, NCD's risk factor related to food intake. Bahrain, since 2017, have taxation on soft drink and energy drink. We are so proud. Bahrain, the first country, followed by Kuwait and Saudi now, selling energy drink to below 18 is prohibited in Bahrain against the law. Maybe you notice in the applications in the shelves of supermarket, it is not allowed to be sold to below 18 years, like this tobacco. One of our top, we call it best buyer project, is to reduce the salt percentage in the bread. There were a long study, 24-hour urine collection, etc., to see, shows that the per capita in Bahrain consumption of salt is very high, mostly coming from bread. الخبز اللبناني, الخبز الإيراني, الرولز, the bread, different type. Because of this, we start we release decree to mandatory identify the percentage of salt in bakery product, collaboration with the public health lab, continuous monitoring. Alhamdulillah, it was very difficult challenge to control the salt among the bakeries, but with workshop, education, regular visit, we achieved that 35% of bakeries in Bahrain achieved the target, 27 near the target, 38 still far from the target. Bahrain adopt the control trans fat in a pre-packaged food. All the food, you saw it in the supermarket, imported or manufactured in Bahrain, the trans fat should not exceed 5%, and it is licensed and monitored by public health. All the label, there is accredited mandatory technical regulation for the labeling, food supplement or the domestic food in Bahrain. Recently, we collaborate with the World Bank to study the effectiveness of in front of package labeling to customer behavior. We wish one day to apply in front of package labeling to be mandatory. One of the recent projects is the healthier choices in vending machine. We start to develop a guideline. We take the approval from the task force committee. We implemented in 7 health centers, 3 locations in Ministry of Health, inshallah next month will be applied in Bahrain University and city center and airport and going on. We wish the idea or the goal of this project to provide the information for the customer and to give the customer the right to choose from the snacks, because we know Bahrain population like to snacking. So we want to provide the information and to make the healthier choice is the easier choice. There is guideline. We launched the project through 2 weeks في سوق المزارعين, the farm marketing, to educate the population, and we collaborate with the local traders to increase the awareness regarding this project. Finally, the food nutrition surveillance guideline, we have many, but one of the most and recent and most important is the first food-based dietary guideline Kingdom of Bahrain, released in Ministry of Health website and followed by a scientific paper by Dr. Mariam Al-Hajri. To make sure that this guideline reach as more from the population, we combine the guideline with sustainable exhibition. So far, more than 1,500 visitors, 90 volunteers, 26 workshops between physical activity, healthy cooker, and mental health. This is a pictures, Dr. Khawla, Dr. Sabich Al-Lahdan from the University, Arij from Malik Hamad, maybe you know them, they are famous in social media. We host a lot of champion with collaboration of Ministry of Youth and Sport. We have our exhibition. It is a very nice interactive exhibition. All of you most welcome to visit our exhibition. We can arrange with the nutrition section. We host many of chefs in Bahrain and give classes of healthy cooking. And the other document, which I'm proud of it, it is a long, big project, the food composition table. Any of you, if you are working in field of nutrition, you will miss some information regarding the traditional dishes in Bahrain. If you want to know the nutritional value for machbous, haris, saluna, you will not find it in the international database. So we develop our database is the food composition table. I wish by April will be published, so everyone have access to it. The food composition, we analyze by the lab the Bahraini dishes, and we get the information regarding macro and micronutrient. It is a very valued document. Will help a lot. We have now the second round for the elderly nutrition surveillance. We cover 108 elderly 60 years and above. The team of 14 Dur Kibar Sen, Parent Welfare Associations, the team of 8 nutritionists and doctors. Until now, we had 1,212 24-hour recall. We're starting the food composition analysis for this 24-hour recall. So far, we finished 931. Inshallah, soon will be published the result. A lot of collaborations. What is next? All this initiative will be continued, monitored, but what is our goal? All this initiative, policy, project, campaign to reach the goal, which to at least stop the obesity among the adults by 2025, reduce the obesity among the children by 5% by 2030. We wish more, but this is a realistic goal agreed by the Task Force Committee and WHO regarding the current situation. How we will make sure that we are in the right track to reach this goal? We set our objectives. There are 5 objectives. increase the exclusive breastfeeding, reformulation the food to be more healthier, less fat, less sugar, less salt, and expand the taxation to involve the sweetened beverage, limited the salt in the bread, increase or decrease the inactivity, physical inactivity, inshallah, improve the national food system in the workplace, universities, hospitals, school canteen, strengthen the growth of surveillance and data in Bahrain, increase the coverage in primary health care service regarding prevention, diagnosis, management, screening. All this will be monitored, and whenever we feel we are far away from the goal, we'll re-evaluate our effort. We have a specific target, as you see here, and inshallah by 2030 we reach this target, or at least to be near this target. All this will be done multi-sectorial with collaboration with governmental and private related authorities. Thank you.
And now we'll move on to the next talk. Dr. Hamdan Neshmi, psychiatry consultant at King Hamad University Hospital and senior lecturer of psychiatry at Royal College of Surgeons in Ireland, Bahrain, will talk to us about obesity stigma. Welcome to the podium, Dr. Hamdan.
Good morning, everyone. Thank you, thank you, Dr. Dalal, for the introduction. So stigma in psychiatry is a very, very well-known subject because we're used to deal with stigma with mental illness. So thank you for inviting me to talk about this. Today's subject is a bit different than the mental health related issues. However, we cannot separate physical well-being from mental well-being, as I always say. So what is obesity stigma? It is discrimination and ideologies targeted towards individuals because of their weight and because of their size. So weight stigma is a result of weight bias. Weight bias refers to the negative ideologies associated with obesity. People with obesity may experience negative verbal comments, teasing, bullying, physical assault, and even the gaze and the body language, even if it's not verbal, can be a source of discomfort for people who suffer from obesity. I have some examples of obesity stigma. People with obesity may face accusations of being lazy, careless, that they lack the strength and they lack the will to control their dietary habits or to be more active. They might be accused of being, of lacking actually moral characters, or they have bad hygiene. And also they can be accused of having a low level of intelligence and being unattractive. Weight stigma at school settings. This is a very important subject. The school and educational environment is renowned for bullying, and weight is one of the primary reasons why our kids are being bullied. Students are not just victimized by their peers. It has been documented also that even their teachers, and especially physical exercise teachers, can contribute to being stigmatized for suffering from overweight. Weight stigma can prevent students from progressing into higher education because their mind will be constantly preoccupied with the way they look. So this can be a big source of distraction from their goals and from education, progression in their educational level. Weight stigma can prevent students from progressing into higher education. Students with obesity are significantly less likely to be accepted to college or universities, and those that do are likely to receive less financial support than their healthy weight peers, as some studies I'll mention later suggest. Weight stigma at workplace. There is consistent evidence of weight discrimination at every stage of employment, including by default in interviews, right? Career counseling, hiring process. Some studies suggest even salaries can differ if you are good looking or not, and if you are fit or not, regardless of your educational level and level of expertise, yes. They tend to get harsher disciplinary actions when compared to other people who have, with a normal BMI, for example. And people with obesity are less likely to be put into sales or frontline customer service. Now, this might be the most important slide or the highlight of our presentation. Us, as physicians, we tend to stigmatize the patients with obesity. Physicians, dietitians, fitness professionals, and exercise science students have all shown a tendency to describe stereotypal characteristics as, don't be lazy. Of course you can do it. Why didn't you lose weight? Like when we compare the weight from a visit to the next visit, especially if the physician and the patient had a talk about this subject in particular. I mean, being realistically speaking, people who suffer from obesity, they know that they are obese, right? And they come for the physicians for different and various reasons. For example, their diabetes or, depression, anything which is health related. When the patient himself doesn't want to talk about it, that doesn't mean that he doesn't know that he has obesity. Now, us as physicians, we tend to advise in general about obesity, just like smoking. You want to tell your patient don't smoke or don't do any bad habit. But if the patient is coming for a different complaint, for example, hypertension, and we keep suggesting lose weight, lose weight, lose weight, and we assume that he's not doing anything, we are ignoring that there are other factors other than the patient being, lazy or just likes to overeat or has emotional eating or something like that. We all know that there is genetic factors of obesity. There are hormonal factors, stress also. People under stress will have their cortisol high and their weight loss process will be slower than expected. Pregnancy, childbearing, all of these factors contribute to being obese. And we all have phases of our lives when we were overweight and we lost weight. This is the human nature, right? What happens in real life when we keep insisting and nagging on the patient's head, lose weight, lose weight, lose weight, they will try to avoid the visits. They will come for medication refill instead of seeing their physician, right? And this will only contribute to increase in obesity. We know that humans, when we blame them for something that they're trying so hard to overcome, they will only go and overeat as a result because of stress, right? And we're increasing the stress hormone as well. So we are contributing without purpose to obesity. This, of course, is not our purpose as physicians. We are trying to enhance the quality of life of patients, but sometimes we tend to do that. So I've talked about this here. Physician can also be a direct source of stigmatizing comments. And there are some studies which mention it. In addition to stigma arising from physician-patient relationship, many people with obesity report a stigmatizing physical environment, like the blood pressure cuff not being, fit for their arm. So this is very embarrassing in the settings of emergency and, like OPD, when they check the vitals. This can include also gowns, surgical gowns, chairs, examination tables, or examination bed that cannot accommodate them. So a lot of patients with obesity will avoid actually physically coming to the hospitals to address all the health-related issues because of the feeling they have when they leave the hospital. They will, even the physician, if he was a pioneer in, for example, in endocrine or diabetes or, heart disease, if the approach to the patient was inappropriate and it lacks empathy, the patient will not come back. And this will, contribute more to health-related complications because of poor compliance. Let's too small here. It describes the cycle of stigmatizing obesity. When we stigmatize it, we will increase the stress, which will increase, eating, emotional eating, and will contribute to even more obesity. Consequences of obesity stigma on mental and physical well-being. Fear of stigma can lead to avoidance of seeking medical care, which creates barriers to obesity prevention and treatment strategies. Weight stigma has been positively correlated with a variety of disordered eating patterns, such as binge eating, emotional eating. We have noticed this throughout the years. When we talk a lot and insist a lot on the patient that you need to stop something, it usually tends to have negative result instead of the result that we want to. There are many scientific studies that are associating obesity to a variety of serious medical conditions. However, more recently, there have been studies with results which indicate that weight stigma plays a fundamental role in the development of some of these medical conditions. For example, it has been found that weight stigma, independent of adiposity, positively correlate with increased stress hormone, as I just mentioned. Stress has been found to impact multiple areas of health, like blood pressure, cardiac health, visceral fat levels, and insulin resistance. We have some cases of weight stigmatization so severe that it has been directly associated with not only anxiety and depression, insomnia, overthinking, even tendency to self-harm, and suicidal ideations. So how do we manage obesity stigma from psychological point of view? By providing and advocating healthcare professional education on obesity, we can reduce stigma among groups, leading to better treatment for people with obesity. By improving awareness about obesity among general public and general population, and challenging the assumption that obesity is always a matter of personal responsibility and personal choice, because we have so many cases that doesn't apply to this condition. The language that we use around this condition remains a major contributor towards stigmatization. It is still usual to see obese people, and a key part of our fight for people first language is to change this to people with obesity. Language is essential, and we have to, watch the words that we say to patients, and watch also our body language and the way we look at them. I thank you so much for attending. I just want to say that stigma in general is increasing, especially in this era where social media is being very unrealistic, very judgmental. We don't only have nowadays weight or obesity stigma, we also have weight loss stigma. Whenever someone tries to choose a healthy lifestyle and choose to lose weight, they will also be accused of lying about how they did it, or accusing them of doing procedures that they didn't do. So at the end of the day, changing stigma, we have to start with changing our mindset and accepting that our human body is changing, according to age, according to priorities, circumstances, and health conditions. Thank you so much for attending, and we open the floor for questions.
Thank you so much, Dr. Hamda. Maybe we can hear from the audience if they have any stories to share about stigma that they have observed in the school setting, workplace, family. Anybody wants to share? Because that's an important thing to talk about.
Thank you very much, Dr. Hamda, for the presentation. One of the places in which I find a very useful place where to give an advice to patients who has got some chronic problem like obesity, like hypertension, like smoking, is that when they come to the emergency department. I'm an emergency physician. My name is Dr. Samarai. Right, and I find it really useful that these patients, when they come to the emergency, when you tell them stop smoking, it's very easy to say it, you know, and especially if he doesn't notice the consequences of smoking immediately. But when he comes to the emergency and there are all these bells and ringing and these other things, and then I think this is a very good time. And there are studies actually showing that the advice in the emergency is really effective. So he will believe that this is really what we are advising him is really serious, you know. So I find that this is very useful. And I take all opportunity when a patient comes with a chronic problem, including obesity, to advise them during this hard situation when they come to the emergency. Thank you very much.
Thank you. And personally, when we are treating individuals with obesity in the clinic, we're always trained to get the person's permission before we open this topic. It is a very sensitive topic. Just last week, I had a lady sit in front of me. I'm waiting for the chief complaint. I'm like, welcome, ahlan wa sahlan, welcome. And she's just sitting there, panting. She doesn't know what to say. And I wait patiently, and then I said, do you want to talk about your weight? And she said, yes. And that's okay. And that's okay. And taking their permission, understanding this burden they've been carrying, all the stories and the stigma in school, at work, in the household, is a burden. So we're now lucky in an era where people are coming to seek medical care, to evaluate, get help. And help doesn't mean medication. Helps mean a holistic approach of lifestyle, diet, exercise, and removing the guilt of obesity. It's not your fault. It's not always your fault. Another thing I really liked about Dr. Hamda's presentation is not to label people with labels like obese patient. Even when you present to colleagues, when you're talking, people are listening. The patient is listening. So don't label a kid or an adult. I have a 35-year-old obese woman. No, that's not. Person with obesity is fine, but obese is not fine. And also, sometimes we are harsh in the medical field. If you see somebody with a BMI of, say, 31 and the weight is 120, immediately you tell them lose weight. But what if I tell you this person 6 months ago was 150 kilos? For them, the 120 is a big achievement. And they are destroyed by your comment, lose weight, like jumping to conclusion. So I wonder if these stories and these things I'm sharing reflect in any one of you that want to either ask or comment something about, Dr. Khadija?
Assalamu alaikum jami'an. I just want to share one case I saw last week, a 12 years old child. He visited me 1 year back, and then I didn't see him. He's non-Bahraini, and he there traveled outside Bahrain, and he came back. He has obesity, but he didn't, he struggled to reduce weight. Okay, this time he came because I knew that he is not going to school, he just do online. And now he wants to go to school, that's why he wants to reduce weight. And what I understand, this has affected him so much, for an extent he is doing online. The time I start to speak with him, he start to cry. We speak alone without the parents, and I knew that he had a lot of pressure from the family itself, from his mother, to reduce weight. And the family wasn't supportive enough. They are thinking they are supportive, but in the opposite way. But for 1 year, he's not going to school because of obesity is too much. And the second thing, I address with him, this is an easy, there is solution. We will start with lifestyle modification. If not, we will go for medication. We have all the solutions. The mother also insists she doesn't want to use any medication, you know. Sometimes in the sitting, you find it's difficult to deal. If you want to, you know, you need to treat all the family. It's not only the child alone. Yeah.
Dr. Mariam here has a comment in the front.
I think this problem facing with the school children, I think we need to educate the teachers, because there is a lot of stigma at school. And I know many of the children, they not like to share in physical activity or even going to school because of this matter. So I think parents, school teachers, they need more education in this matter, because there is a lot of problem at school among the children who have overweight and obesity. Thank you.
And I don't know about the services available in terms of psychological support in such interdisciplinary clinics, whether it's adults or children. Dr. Hamda, maybe you can tell us more, like in primary care setting or secondary care setting, how much support, because I think their role is even more valuable than our role at the beginning to counsel the kid or family and the person.
Yes. We get referrals actually, Dr. Dalal. We are part of bariatric team. We do psychological assessment to look for other reasons of obesity and to evaluate the fitness of procedures since it's a permanent procedure. We do also collaborate with endocrinologists to see if, especially in children category or adults, which we suspect cognitive decline. So we do assess them before we start this kind of treatment. And in a lot of cases we see people who are fit for that, and in other cases we see people with a certain mindset that needs to be changed before undergoing procedures, before using weight loss injections, because if we don't work on the mindset and our relationship with food, obesity will come back even after bariatric surgery or even after they are done with using weight loss injections.
Thank you, Dr. Hamda. Thank you, Dr. Dalal. I believe that regarding the obesity, it's a start, we have to educate the parent since the childhood, because in our community, they look for the chubby child as a healthy, cute child. I still remember when I had my children, they used to tell me, why your children is very thin? Like, ليش ما تأكلين عيالك؟ عيالك وايد thin, ضعاف، ما تأكلينهم. No, they are healthy. Chubby doesn't mean healthy.
True. Our like in Bahraini words نسميه بعافية، الولد بعافية. عافية stands for extra health, right? أو حتى في بلاد الشام صحة ناصح. They don't address, here in our Arabic society, we don't address issues as it is. We tend to give them names, and this, yes, might manifest to accepting it, and then this will increase as the child grows up, isn't it?
Yeah,
right?
That's why it starts from the childhood.
That's true.
Then it will continue.
Although prevention here is 1,000,000 times better than treatment, because raising a kid who's healthy, eating fruits and vegetables and lean is way easier than dealing with a teenager with obesity. Way easier. Doctor?
Adding for your question, Dr. Dalal, while I'm working for the acceleration plan to stop obesity, we were trying to find a mental health related initiative in Bahrain regarding combating obesity. The only initiative we found, as you said, Dr. Hamda, is just the committee regarding the bariatric surgery. It was very sad, even through the governmental and even private sector, unless if the patient come by himself to ask for help from the doctor. Otherwise, there is no clinic or initiative or any project that target the mental health with an evidence-based mental health intervention to reduce or treat the obesity. From your experience, or maybe you exposed to a benchmark other countries' experience, what you wish to see in Bahrain and mental health related initiative that you believe it will help to address and reduce obesity in Bahrain?
As a mental health professional, I want to use this opportunity, since we are all concerned from different specialty, to start an initiative actually to include mental health professionals in this initiative. Let's take this conference as an opportunity and start this initiative. Yeah, why not? We'll be glad to join, yeah.
Yes, we both serve in same committees for combating NCDs. So I represent the Diabetes Society and the NCD committee, and this is something we can raise to them, of course. So thank you all for your contributions. Dr. Hamda? All right. So cheer up, lift up the mood. I think some people are like زعلوا موضوع الاستجمة فرحوا شوي. So We will now talk about complications of obesity. Dr. Hassan Farooq, consultant endocrine and diabetes, Salmania Medical Complex, and he's been with us in the previous wave as well, and we welcome you to the podium.
Thank you very much, Dr. Dalal and Her Excellency Dr. Mariam, for inviting me to be a part of this meeting, which it's always my pleasure to work with such a group. Good morning, everybody. Thank you very much for your attending. After we hear about the stigmata of obesity from Dr. Hamda, and here we have a lecture about a complication of obesity. I will not go through all the obesity's complication, but basically we'll just highlight the most important part of this complication. I will start my slides with the prediction for global prevalence of obesity. As you can see here, it's been estimated by 2030 that about 1 billion people will be lived with obesity worldwide. And as you can see here on the right hand, that the prevalence of obesity over time is increasing among different class of obesity, whether class 1 or class 2 or class 3. As you can see, in 2030, about 12% of class 1 obesity will be increased in compared to 2010. So obesity meets the common criteria of a disease. So actually, what is the definition of health is a state of complete physical, mental, and social well-being, and not merely the absence of the disease or infirmity. So obesity is considered as a disease nowadays, not only as a symptoms. So according to the American Medical Association criteria for a disease, to have a disease, you have to have a criteria. So the criteria is to say that this is a disease, you have to have an impairment of the normal functioning of some aspect of the body, then associated with the sign and symptoms. After that, it will harm or make the morbidities. So obesity is considered one of these which fulfill the criteria of a disease. As you can see, there will be appetite dysregulation, abnormal energy balance, endocrine dysfunction, infertility, non-alcoholic fatty liver disease, and dyslipidemia. And that itself, which will lead to increase the body fat, and the symptoms which increase by this increasing in the body fat and adipose tissue, especially with the joint pain, altered metabolism, shortness of breath, and that will be a leading to consequence type 2 diabetes, cardiovascular, hypertension, and these all complications. So obesity is recognized among different societies, different organizations. It's as a disease which needs to be tackled. As you can see, according to the World Obesity Federation, where they consider that obesity is a chronic progressive disease, poses need for an immediate action, prevention, and control for this global epidemic. And according to the Obesity in Canada, they consider that obesity is a progressive chronic disease similar to the diabetes or high blood pressure. And according to the academic nutrition and dietitian, they consider that you need to treat and reduce the obesity by qualified practitioner, dietitian, and nutrition to more effectively treat the disease which impacts more than 1/3 of our nation. And as you can see, according to the Asian Association for the Study of Obesity, they consider obesity as a pathological state in which a person suffers health problem caused by or related to the obesity, thus making the weight loss is clinically desirable. So the life expectancy decreased, of course, once the BMI increased. As you can see here, if the patient have a normal BMI, he has an 80% chance to reach the age of 70. But this is much reduced when the patient have a BMI 35 to 40, and the chance to reach the age of 70 is almost 60%. And this will further reduce once the BMI is more than 40, where the chance is only 50% to reach the age of 70. So obesity is associated with a multiple complication. You can name any complications, definitely it will be related to the obesity. But among the studies, they found that more than 230 plus complications affecting every organ and different specialties. And among these complications, some of these complications really has a very strong relation to obesity, and some of them, they might have a little bit less than that with a strong association, and some of them with moderate association with obesity. So obesity is associated with the multiple complications, as we said, and this is usually related either to metabolic effect of obesity, which we can find these complications might happen in terms of cardiovascular disease, either stroke, dyslipidemia, hypertension, coronary artery disease, or heart failure with preserved ejection fraction. Or you might find diabetes and its complication with prediabetes or type 2 diabetes, thrombosis, gout, non-alcoholic fatty liver disease, gallstone, infertility, and sometimes might lead to cancer. While due to the mechanical effect of obesity, you might find other complication which considered as a sleep apnea or obstructive sleep apnea syndrome, chronic back pain, asthma, incontinence or urinary incontinence, knee osteoarthritis, physical dysfunction, and gastroesophageal reflux disease and intestinal complication. While according to the mental mechanism of obesity, as Dr. Hamda, she's already expressed that, in term the patients might have depression and anxiety, which in turn relate to obesity. So the prevalence of complication in people with obesity, it's actually wide. Once the body mass index increases more than 30, then you might find that 50% of the patients, they might have hypertension or knee osteoarthritis. 40% they may have obstructive sleep apnea. 35% they may have a gastroesophageal reflux syndrome. 30% they may have non-alcoholic fatty liver disease, myocardial infarction. 20% major depression and diabetes, and about 10% ischemic heart disease and PCOS. So what is actually the pathophysiology beyond these all complications? Once the obesity is there, then there will be a lipotoxicity. And once the lipotoxicity is there, then increase in the visceral fat, which will lead to increased insulin dependence, increase lipolysis, increase the portal free fatty acid circulation, and it will lead to increase the cytokines and the macrophage and decrease the adiponectin. And these, once it's increased in the body, it will go and accumulate in a visceral adipose tissue and associate with the fat accumulation in other organs, especially the liver, the pancreas, the heart, and the muscle, which will lead to lipotoxicity in these organs. And the benefit of early intervention is always you should emphasize about reducing the body weight as early as possible. So treating obesity early can reduce the risk of developing chronic, expensive to treat complication, and a patient with no existent complication going from obesity class 1 to overweight would reduce the risk of developing type 2 and obstructive sleep apnea by more than 50%. And you can see here on the table that if you have a normal BMI, or comparing to those patients with a BMI more than 30, which is class 1 obesity, or those patients with overweight with a BMI 25 to 29.9, you find that if you reduce your weight, then you have a 5% chance, if you're overweight, then you have a chance 5% to have type 2 diabetes if you are class 1 obesity and sleep apnea, and you have 2.5% chance to develop these complications if you are just overweight. So what will happen if we reduce our weight? What you will get a benefit? Actually, they found in the studies that if you reduce about 5% of your body weight, your hypertension and hyperglycemia will be much improved. And if you reduce more, about 10%, then probably there will be improvement in the polycystic ovarian syndrome, non-alcoholic fatty liver disease. You might prevent to develop type 2 diabetes if you have impaired fasting or a pre-diabetic state, and dyslipidemia definitely will improve. But if you reduce more than that by about 15% of your body weight, then probably there will be a cardiovascular benefit, reduce the obstructive sleep apnea, and improve the gastroesophageal reflux syndrome or disease. And if you reduce your body weight by about 20%, there will be a reduction in cardiovascular mortality and improvement almost improvement of hepatic steatosis. And if you reduce more than 20% of your body weight, and that's what we usually find with the patients underwent bariatric surgery, they usually went into a remission of type 2 diabetes. So the most patients with overweight can achieve significant weight loss and health benefit and improved their quality of life. And a study has been shown here that if you reduce your body weight more than 10%, that will show that there was much improvement in quality of life among these patients, including their physical function, self-esteem, sexual life, even work, and public stress. So reducing the body weight will improve definitely the quality of life. So what is the effect of obesity on specific complications? We're going to talk about type 2 diabetes, cardiovascular disease, heart failure with preserved ejection fraction, osteoarthritis, and non-alcoholic fatty liver disease. So talking about type 2 diabetes, studies being shown that comparing women and men, when they have like more than 35% of BMI, women having a higher, much risk of having diabetes than men. As you can see here, if your BMI more than 35%, then you have probably 100% chance to get diabetes. While comparing to men, they have almost 50% chance to have diabetes. Obesity is associated with increased insulin resistance and type 2 dyslipidemia. So what's basically happened when the patient is obese, there will be increase in a white adipose tissue, and that will lead to increase the free fatty acid and the tumor necrosis factor and some inflammatory markers, including the interleukin-6 and the cytokines. And that inflammatory markers will cause inflammation, insulin resistance, and of course hyperglycemia and type 2 diabetes. While increasing the free fatty acid will go into the circulation, that will lead to impaired the receptor of insulin sensitivity and insulin dysfunction. That will cause a lipotoxicity and itself will lead to type 2 diabetes and impaired fasting. So obesity, prediabetes, and type 2 diabetes are a disease of continuum. So always we said that patients with type 2 diabetes, they have diabetes or impaired diabetes or prediabetes maybe 5 years before diagnosis. So as you can see here, when you start to have obesity, so there will start the patients to have insulin resistance. And once the disease continues, then there will be a beta cell compensation and beta cell decrease in function, and that will cause increase in insulin resistance. And at the end of the day, the patient definitely will develop decreased insulin secretion and type 2 diabetes and beta cell failure. Weight loss reduces the risk of type 2 diabetes, definitely. Once you reduce your weight, definitely there will be an improvement and reduction in your blood sugar and improvement in your diabetes. So a study has been shown here that comparing patients using metformin or only going through the lifestyle modification, you can see that there is a 34% reduction comparing to those patients using metformin only by doing lifestyle change in terms of developing type 2 diabetes over the 10 years. So reducing your weight definitely will protect you from getting type 2 diabetes. Effect of obesity on cardiovascular disease. It's been estimated that about 500 million people in 2019 had cardiovascular disease, and among those patients, 32% of global death are due to the cardiovascular disease, and 49% of global cardiovascular death are due to the coronary heart disease. And it's estimated in 2020 that about 1,000 million people estimate to live with obesity, and this number will reach to about almost 1,500 million people with 2030. And excess weight promotes cardiovascular disease via multiple mechanisms. Of course, once the BMI increased, there will be an increase in the blood pressure, increase in blood glucose, increase in insulin resistance, increase in blood lipid, as well as increase in inflammatory marker. And that itself, which will lead to atherosclerosis, and at the end of the day, formation of thrombus, and as a consequence of that, you might get an MI, stroke, or peripheral arterial disease. But again, the difference that once you reduce your body weight and BMI, so there will be an improvement in all these markers, including the blood pressure, blood lipid, blood glucose, insulin resistance, inflammation, and of course, you will reduce your comorbidities and mortality from cardiovascular disease. And what happened actually when the weight loss improved the lipid metabolism and reduced the level of inflammatory markers, as the studies being shown that among all the inflammatory markers being shown clearly that's been reduced much once you reduce your body weight. And if you can see, if you reduce your body weight about 16%, there will be improvement in all the inflammatory markers, including the intra-abdominal adipose tissue, intrahepatic triglyceride, C-reactive protein, and the free fatty acid if you reduce your body weight by almost 16%. Increasing overweight and obesity is related to the cardiovascular death, and as you can see, 19% of global congestive heart disease or coronary heart disease deaths are due to the higher BMI, and about 2 million cardiovascular deaths were attributed to elevated BMI in 2021. And 70% of deaths related to the overweight or obesity are due to the cardiovascular disease. So while cardiovascular mortality has decreased over the past 2 decades, overweight and obesity-related cardiovascular death increased indeed by threefold. So the link between obesity and cardiovascular disease is very closely linked to each other. As you can see, once the patient is obese, there will be increase in systemic inflammation and inflammatory markers, and that it will lead to increased endothelial permeability, increase the plaque development and atherosclerosis, and that will be a consequence of developing the cardiovascular disease, MI, stroke, and peripheral arterial disease. And obesity as a risk factor for cardiovascular disease, you can see that obesity is one of the modifiable risk factors that you can always reduce it and prevent the complication. And once the patient is obese, of course, that will lead to increase all these markers, and that consequently will lead to atherosclerosis, thrombosis, and of course the cardiovascular mortality and morbidity. But not only that, if the obese patients, for example, if you have only patients obese without having diabetes or other metabolic abnormalities like diabetes, hypertension, or dyslipidemia, they found that obesity alone also can contribute to cardiovascular mortality in these patients. So you can see if the patient's having high BMI, then he has also again increased risk of developing a coronary heart disease, cerebrovascular disease, and heart failure, even without having type 2 diabetes, dyslipidemia, or hypertension. Effect of obesity on heart failure with preserved ejection fraction. Heart failure with preserved ejection fraction manifests as a non-specific disease, and it's associated with multiple comorbidities actually. It might associate with chronic kidney disease, coronary artery disease, type 2 diabetes, atrial fibrillation, hypertension, and obesity in about 80% of these patients. And often 2 out of 4 comorbidities usually coexist with heart failure with preserved ejection fraction. And obesity leads to increase the incidence of heart failure with preserved ejection fraction. As comparing patients with obesity with those patients with a lean body, they found that there is a much increase in heart failure with preserved ejection fraction among these patients. Effect of obesity on non-alcoholic fatty liver disease and NASH. Patients with obesity or type 2 diabetes are at increased risk of developing NASH, and that's basically, if you compare patients with type 2 diabetic with those patients with obesity, you'll find that 41 million patients with obesity had NASH, comparing to those patients with type 2 diabetes, about 10 million patients with type 2 have NASH. And obesity is a pathophysiological drive for non-alcoholic fatty liver disease. 70 to 80% of people with obesity have non-alcoholic fatty liver disease, and obesity is associated with three times more risk of developing non-alcoholic fatty liver disease. And 51% of non-alcoholic fatty liver disease patients have obesity, and usually even non-alcoholic fatty liver disease associated with increased waist circumference. So obesity is a key driver for non-alcoholic fatty liver disease. As you can see that diet-induced obesity, once the patient is obese, there will be increasing in metabolic stress and increased systemic inflammation and fibrosis, which affect the liver, and that itself will lead to cardiovascular, liver, and subsequent cancer in these patients and increase mortality among obese patients. Increasing the benefit of weight loss and on NASH and fibrosis, you can see there's a very nice studies actually showing that if the patient reduce their body weight by about 5%, they might have a resolution in NASH in about 10%. But if you lose your weight more than 10%, there will be a resolution about 90% in a NASH and about 80% in fibrosis. And look to the steatosis improvement. 100% these patients would be improved once they reduce their body weight by more than 10%. What about obstructive sleep apnea? Obstructive sleep apnea and obesity is being shown that more than 80% of adult patients with obstructive sleep apnea have overweight and more than 50% have obesity. And studies suggest that approximately 25% of adults with a BMI between 25 to 28, that's an overweight, they have at least mild obstructive sleep apnea. And in 2017 studies showing that if you have more than 40% BMI, 75% of these patients have severe obstructive sleep apnea. So increasing in a visceral adipose tissue amplifies the severity of obstructive sleep apnea. And what happens in obstructive sleep apnea, usually the visceral obesity and neck circumference are more specifically related to the development of obstructive sleep apnea. An increase in a visceral adipose tissue, which lead to increase the higher level of cytokine and adipokine secretions, and then development of obstructive sleep apnea in these patients. And despite of early recognition of strong association between obstructive sleep apnea and obesity, and obstructive sleep apnea and cardiovascular disease, but still actually this disease not being tackled properly and is considered only a locally abnormalities for the respiratory tract rather than to be a systemic illness. So a patient, if he's obese, there will be a fat deposition in upper airway and smaller airway that will cause the obstructive sleep apnea, and then the sleep fragmentation and sleep restriction. And this, once the patient is having obstructive sleep apnea, there will be decrease in the insulin growth factor 1, and that will lead to intermittent hypoxemia. And once the patients went to hypoxemia, there will be increasing in aldosterone, angiotensin, cortisol, leptin, which these all contribute to develop the hypertension. And of course, once the patient is hypertension, he has a risk of having cardiovascular risk, insulin resistant, and hyperinsulinemia. So obstructive sleep apnea definitely need to be tackled early and treated once the patient is just overweight or have mild symptoms of obstructive sleep apnea. And obstructive sleep apnea is a condition where one airway becomes blocked repeatedly while sleeping, causing interrupted breathing, snoring, or gasping, and low oxygen level, and subsequently daytime fatigue. And lifestyle change, avoiding alcohol, losing weight especially, and stopping smoking may elevate your obstructive sleep apnea symptoms, and mild to moderate obstructive sleep apnea may be almost improved if you at least lose from your body weight of about 15%. And obstructive sleep apnea being tackled by many organizations. According to the American College of Physicians, they consider that obstructive sleep apnea has strong recommendation to encourage people with obesity, overweight to lose weight. And according to the Institute for Clinical System Improvement, because a patient encouraged to be compliant with the weight loss treatment plans, pharmacotherapy, and bariatric surgery, which can be considered at a lower BMI in patients with obstructive sleep apnea than in patients without comorbid conditions. And according to the American Academy of Sleep Medicine, they consider weight loss for people with obesity, overweight, it's always been recommended. An effect of obesity on chronic kidney disease. as you can see, obesity among one of the factors which affect the CKD patients, including the diabetes, the hypertension, the family history of CKD, atherosclerotic cardiovascular disease, age, and nephrotoxin, and smoking. And obesity with a chronic kidney disease shown that approximately 44% of CKD patients have obesity, and obesity is estimated to account for approximately 20 to 25% of kidney disease worldwide. And obesity usually increases the burden of disease. If you have a CKD and you are obese, so you increase the burden of the disease itself. So a patient with overweight or patients who live with obesity, usually they have a complication including the CKD, then there will be a 24% reduction in their quality of life, plus if they have already a CKD. And there will be increase in the mortality rate among these patients comparing those patients without obesity or patients with CKD and obesity. So 7% increase in their morbidities and mortality if you are just obese and you have CKD. And of course, there will be a complication regarding transplantation. So higher wound complication, longer hospital stay, delayed graft functioning, and graft failure, and higher mortality among those patients with obesity. And the need for dialysis in these patients will be much complicated because at the end, you need to reduce, there will be a reduce in access to outpatient hemodialysis therapy due to the weight limitation in these patients. And according to the KDIGO guideline, the kidney disease improving global outcome, usually they state in their guideline that physicians should consider advising, encouraging patients with obesity, diabetes, and CKD to lose weight, particularly in patients with estimated GFR more than 30. And my final slide and message to be taken home that obesity is a global health imperative. Obesity is a chronic progressive disease, not a lifestyle choice driven by genetic, social, or environmental factor. And about 1.5 billion people worldwide are projected to have obesity by 2030, escalating the risk for almost 200 plus complications across all organ systems. And the key complication is type 2 diabetes, cardiovascular disease, non-alcoholic fatty liver disease, kidney disease, cancer, and mental health disorder. And early interventions save lives. About 5 to 10% weight loss reduction will save the complication, like it will be reduced diabetes by about 50% and improve the quality of life. Multidisciplinary care involving dietitian, physician, mental health expert, and public health action always needed and critical to curb this epidemic and act now, not tomorrow. Address the obesity to prevent its devastating ripple effect on individual and healthcare system. And it's always your choice, ladies and gentlemen, whether to choose the A or the I to make your body fit or fat. Thank you very much.
Are there any questions from the audience? I'm pretty sure, Dr. Hassan, you convinced everybody that it is a disease, that fatty accumulation of fatty tissue is not just something sitting under the skin or within organs, but it has all these consequences on health, and interventions are definitely necessary. Any questions? Yeah, Dr. Samarai.
Thank you, Dr. Hassan, for the excellent presentation, especially the very informing statistics you have presented, and I really appreciate it. And actually, each slide it needs a separate lecture, because you've touched on different specialties. And I think a major problem is that the mainstream medicine, the doctors, they are actually not very much aware of these complications. And if you go even to the medical schools, and you see how much time is allocated for nutrition and obesity and this and that, you find it very, 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 very modest, very little actually. And when they come to talk about obesity, they just enumerate, the causes of cardiovascular, number 1, number 2, diabetes, one of them is overweight, and that's it. And the mainstream medicine is very much controlled by what we call the drug pharma. You have so-and-so disease, take that medicine. So-and-so disease, take that medicine. How about nutrition? How about overweight? You know, and I'm sure many of the doctors are not very much aware of the literature of nutrition, including me, I'm telling you. I regard myself as one who is really following this research about nutrition, but still all the time, every day I'm surprised that I know very little about that subject. And only I would like to thank you, Wallahi, very much. I can't say anything more. Thank you very much.
Thank you, Dr. Samra. Thank you very much, Dr. Samra.
And if I may comment on that, Bahrain Diabetes Society, for that particular reason, has taken that initiative to create days like these and others, and conferences and academies, to promote this understanding and awareness from multiple aspects. We're now trying to secure a fund to repeat the Obesity Academy program, which we've done before, and that included extensive online training for clinicians, dietitians, where you will learn all that it takes about healthy lifestyle, etc., and a holistic training with certification in obesity management. So hopefully, for attendees who come here to the first wave, second wave, and third wave, we'll be able to secure some of them seats on this online scope modules from the World Obesity Federation, an accredited program for obesity training.
Thank you.
So, certificate of appreciation. Thank you so much.
I want to share with you that we would like to thank our government, Bahrain government, that day before yesterday there is a sport day, اليوم الرياضي, half day that we have to do physical exercise. That's why we have support from the higher authority in Bahrain. And this will help us in reducing overweight and obesity in Bahrain. Thank you very much.
And then next we will have our dear colleague, Dr. Khadija Ali, who is a senior consultant pediatric endocrinologist and diabetologist at King Hamad American Mission Hospital. And she will speak to us about how to evaluate patients with obesity in pediatric clinics. Please, Dr. Khadija.
Good morning, everyone. I'd like to thank Bahrain Diabetes Association, Dr. Mariam and Dr. Dalal for their invitation. I'll talk about how to evaluate childhood obesity in the clinic. Okay. These are my objectives. Before going to evaluation, I want just to raise that it's a serious problem that in 2024, the World Health Organization reported over 390 million children and adolescents aged between 5 to 19 years were overweight, with 160 million living with obesity. So it's a huge numbers. This is in 2024. And in order to evaluate a child with obesity, we should know what is obesity means. The term obesity refers to an excess of body fat, but how can we measure the body fat in the clinic? There are so many methods to measure the body fat in the clinic, but these are non-practical. We are not using it in the clinic. In the clinic, we want something to be easy to be done. So we use body mass index to measure the overweight and obesity for children 2 years of age and older. We don't use it in children less than 2 years of age. We use weight for recombinant length, and if it is more than 97th percentile, we consider it as an obesity. We use this chart for less than 2 years old. Because children grow in height as well as weight, the norms for BMI in children vary with age and sex, not like the adult is a fixed numbers. As children approach adulthood, the threshold for defining overweight and obesity 85th and 95th percentile for BMI, approximately 25 and 30 kg per meter square, which represent the same threshold for defining overweight and obesity in adults. The term morbid obesity is discouraged because it may have pejorative connotations to patients, and we use it inappropriately to describe severe obesity rather than we are using it to describe obesity with related comorbidities. So, BMI, by using percentiles chart, underweight less than 5th percentile for age and sex, normal weight between 5th and 85th percentile, overweight more than 85th percentile and less than 95th, and obesity, same as an adult, we have a class 1, class 2, and class 3. Class 1 more than 95th percentile equal to 30 kg per meter square. Class 2 more than 120% of the 95th percentile, which equal to 35 kg per meter square, and class 3 equal to 40 kg per meter square. These are the BMI charts. We can see by the color, the orange down is underweight, the green is the normal, the yellow is the overweight, and the pink one is the obesity. And here, just to show if we have same BMI, like 23, in two different children, it will not be the same. 23 for 10 years old child considered as an obesity, but 23 for 15 years old child considered as a normal. That's why we use the percentiles. We are not use a fixed number. There is a fixed number per age. There is a tables also we can use. Is the BMI accurate? It's not accurate 100%. It cannot differentiate muscle from adipose tissue. And for stunted population may have an increased BMI without increase of body fat. And if you want to evaluate a child with obesity, we should keep in our mind the widened differential diagnosis. Most of the cases what you see in the clinic will be the exogenous obesity, more than 95%, the simple obesity. But 5% might have endocrine causes, might have monogenic causes, syndrome. So keep this in your mind while during your evaluation of a child if he presents with obesity. So we start our evaluation by taking a history, starting by knowing the age and the onset of the obesity, of the weight gain. Gradual onset is usually typical for most of the common form of obesity, the exogenous one, which is a genetic predisposition combined with excess caloric intake or other environmental contributors. The abrupt onset, it might have, a psychosocial trigger, such as loss in the family or change in a family like divorce, or there is a new symptoms of anxiety or depression. Also, it might be related to medications that cause weight gain, like antipsychotic medications and other, or can be tumor. So if there is an abrupt onset, if they said it just during 1 month, there is a huge increase in the weight, we should consider it more seriously. If there is severe early onset, it means below 2 years of age. If there is a history of weight gain, it's most probably to be a genetic cause for that. It can be monogenic or syndromic. But in the syndrome, some of the syndromes, they used to be failure to thrive and increase their weight only after 2 years, like Prader-Willi syndrome. In history, we focus at birth weight and length, gestational age at birth, maternal gestational diabetes, infant feeding, including duration of breastfeeding. We ask about growth and development. That will help a lot if there is any delay in milestones. It can be linked to the syndromes. Endocrine symptoms, polyuria, polydipsia, menstrual irregularities, constipation, hair loss. Schooling will give us a clue about his intellectual, because some syndrome associated with low IQ, like Bardet-Biedl syndrome and Prader-Willi syndrome. Also, we ask about snoring, restless sleep, morning headaches, generalized tiredness, excessive daytime sleepiness, as well as hyperactive, inattentive behavior in young children as manifestation of sleep apnea. We ask about headaches, which can indicate there is an hypertension, underlying hypertension, musculoskeletal symptoms related to hip or knee, if there is any pain or limitation in a movement. In a pubertal girl, we ask about, or we can see also if there is acne, hirsutism, and ask about the pattern of the menses to screen for the possibility of PCOS, polycystic ovaries. Pediatric overweight and obesity associated with earlier breast development, pubarche, and menarche in girls, precocious puberty, and advanced skeletal development in boys as well. But we usually see this in girls. Girls present with precocious puberty if they are obese. Some boys, they can have delayed puberty because they exhibit delayed testicular development. Ask about the dietary behaviors is very, very important, the previous and the current one, quantities of sugar-containing drinks, high energy foods, and intake of fruits and vegetables. Ask about recurrent episodes of dieting, signs of pathological hyperphagia, such as eating large portions very quickly, being difficult to distract from food, signs of disordered eating, such as binge eating, and the dietary patterns, eating breakfast, if there is breakfast or not, regular meal, snacking, eating outside home, in the restaurant. Very important to ask about physical activity and sedentary activity reflected in the hours spent in the screen-based activity per days. Family history is very important. If there is a similar history of obesity or any comorbidities that mentioned by Dr. Hassan, type 2 diabetes, hypertension, dyslipidemia, premature cardiovascular events or death, and check also with the history, the family capacity to make and sustain behavioral changes and support behavioral change in the child. If you want to start with him, the management. Psychiatric symptoms already mentioned by Dr. Hamda about school absence, teasing and bullying, anxiety, depression, self-harm, anger, if there is any alcohol or drug use, or eating disorders. And last, we should ask about the medication use that might cause obesity, like glucocorticoids, tricyclic antidepressant, antipsychotic, anti-epileptic medication, sulfonylureas, and insulin. When you have an idea of the history, go with the examination. Start by the vitals, weight, height, and BMI calculation. Put it in the graph to see in which, is he overweight, is he obesity class 1, class 2, or class 3. Short stature, a low growth velocity may indicate an endocrine cause if he is obese and short, because the exogenous obesity or simple obesity, they're usually tall and obese. Measure the waist circumference, and they are graph specific for it. This will indicate the insulin resistance. Blood pressure is very important to be measured in each visit. After taking the vitals, go with the examination, see if the child have any dysmorphic features or neurodevelopmental abnormalities. Does he have moon face, stria in abdomen, acanthosis nigricans and skin tags? There is any extreme acne, hirsutism in pubertal girls. The joints, any tenderness and range of motion of the knee and hip. If there is any peripheral edema, any goiter, hepatomegaly. Assess the pubertal stage by tenoring, and do at the end fundoscopic examination to rule out papilloedema. This is a case of type 2 diabetes on metformin, 13 years old, and we can see the acanthosis nigricans. Acanthosis nigricans is not only in the neck, can be seen in any folds like in the abdomen, in the axilla, and skin tags as well. Hirsutism. This child has moon face. He has he's taking cortisol for a long time for his problem. This child has scars in both his feet and both his hands. Do you know what he might have? He's an obese child in the clinic. He has scars in both hands and feet. No. He just did an operation. He had extra digit, 6 fingers, both in feet. It comes with Bardet-Biedl syndrome as a syndrome. During the examination. And usually they wear also glasses, and they are mentally retarded, obese, with acanthosis nigricans. They have retinitis pigmentosa. See how obese, how fat there is. And for this child, they refuse all the medication given. See how sometimes the family is also not supported for the child. This child, she has also deformities in her lower limbs. These are just from my clinic, some of the cases. So when you take a history, thoracic history, and physical examination, now you have at least an idea in your mind in which direction you will go. Is it a simple obesity that you will start with lifestyle modification? Did you suspect any genetic or endocrine that you can refer? It depends on your evaluation. So history and examination will give you many information. Okay, then you can start to screen. Whom you will screen? Most of the recommendation advise to screen overweight and above. Any percentiles more than 85 percentiles. The screening include dyslipidemia by doing fasting lipid profile. Most of them start more than 10 years of age, but not necessarily more than 10 years. Sometimes you can start earlier if there is many risk factors. Okay, doing for hypertension, measurement of the measurement of the blood pressure in the clinic. Check for non-alcoholic fatty liver disease, or now called metabolic dysfunction associated steatotic liver disease, by measuring the ALT. Some of these screening, the patient is asymptomatic, others might they have symptoms. Gallbladder disease, because the gallbladder can be associated with obesity, by doing abdominal ultrasound, liver function test. Look for type 2 diabetes by measuring fasting glucose, HbA1c, or oral glucose tolerance test. Check for sleep apnea by doing sleep study, and others. So history, examination, screening, and now you'll go for management. Always we start the management by lifestyle modification, which is diet and exercise. Then we go to pharmacotherapy and then bariatric surgery. In lifestyle modification, just a few tips in the clinic we can tell the patients. We can refer them to the dietitian. Just guidelines for breastfeeding, we prefer always exclusive breastfeeding because it's associated with decreased risk of obesity later in life. For milk in children, cow's milk should begin at age of 1 year, not before that. Whole milk is recommended until the age of 2 years because whole milk we need the fat, the children need the fat for brain development. So it's needed for 2 years of age. 2% milk is recommended at age of 1 year for children who have risk factors for obesity. Skim or 1% recommended for all children and adolescents age more than 2 years. Fruits and vegetables, at least 5 fruits and vegetables are recommended per day. Sugar sweetened beverage should be strictly limited or avoided entirely. For meal structure, breakfast is very important, is recommended. Don't skip a breakfast. Families should eat meals together as often as possible. TV devices should be turned off at mealtime. Portion size should be age appropriate, and self-regulation. Encourage children to try new and varied foods, but should be allowed to self-regulate portion size. Bribes for a clean plate should not be used. We discourage that, telling the child, finish your plate and we will go for a trip. Finish your plate and I'll buy a toy for you. Don't force the children to finish their plates. Food intake should not be forced or excessively restricted. The evidence showed that when children are allowed to serve themselves by themselves and take the portion for themselves, they give themselves less food than when a plate is prepared for them by the adult. Activity is very important. 1 hour of physical activity a day. Beginning at age of 2 years, TV, computer, any electronic devices should be limited to less than 2 hours a day. No devices below the age of 2 years. The role of 9-5-2-1-0, 9 hours of sleep, 5 fruits and vegetables a day, less than 2 hours screen time a day, 1 hour physical activity a day, and no sugar sweetened beverages. It's very, very useful in your clinic if you can have educational material to give to the family and to give to the children. I do it myself, and it is very useful with a simple language for the parents and for the family. In our hospital, we have a partnership with Mayo Clinic, so we have these education material are ready with different language that we can use about like fruits and vegetables, screen time, physical activities. Okay, eat well and grow strong. And these are booklets, like these booklets of 12 pages, very easy language for kids to understand, and you can give them in your clinic if you can prepare material that will help. Okay. Lifestyle modification is always, I refer to the dietitian. We cannot live without the dietitian. And if it failed, lifestyle modification failed, we go to pharmacotherapy. I find some resistance to start the children with pharmacotherapy, not like the adults. Many of the parents refuse starting pharmacotherapy, but some do, but many of them, they refused. Pharmacotherapy, as I mentioned, only after a formal program of intensive life modification has failed to limit weight gain or ameliorate comorbidities, discontinue medication, and reevaluate the patient if the patient does not have a 4% BMI reduction after taking anti-obesity medication for 12 weeks at the medication's full dosage. The best pediatric pharmacotherapy outcome are among patients adhere to lifestyle program recommendations. Appropriate use require prescribers are familiar with the benefits and risks, counsel and monitor patients appropriately, and support ongoing intensive health, behavior, and lifestyle treatment with a close follow-up. This combination of expertise in life treatment and pharmacotherapy is typically offered in a multidisciplinary team weight management program, but can also be offered by individual clinicians who develop a necessary expertise, because you cannot find full multidisciplinary team in all the centers, like we lack psychologists, dietitians sometimes available or not. You can start it by yourself and refer to the others. So in pharmacotherapy, the first line now, the recommendation, first line is the GLP-1 receptor agonist in pediatric also. We have semaglutide, which called Wegovy, and liraglutide 600. These are the two approved ones to use for weight reduction, 2 years and above. Semaglutide in weekly basis. It's not available in Bahrain. It will come soon in 2025. And liraglutide is available. Liraglutide is once per day. Okay, and it has side effects, GI side effects like nausea and vomiting, and the mean weight loss in 1 year found in semaglutide around 17.7 kg, around 6 BMI loss 6 kg per meter square, and for liraglutide the loss around 1.6 kg per meter square. The other medication, phentermine, tobramate, which are combination of two medication, also to be used after the age of 12 years. Both these medication has high efficacy. Also acetaminophen, but this one is used only for special cases who have genetic causes, central genetic causes, or who have leptin resistance deficiency, leptin resistance, or other causes like Bardet-Biedl, and can be used as early as 6 years of age. There is moderate efficacy. Phentermine alone can be used, approved for 16 years and above. And low efficacy, we have metformin and orlistat. For me, I'm using metformin, and I found on it result, especially in kids who have a prediabetes or who have insulin resistance, polycystic ovary. I found it safe, and the family can take it rather than when I ask them to take injection. And the injections is expensive, metformin is cheaper. But many of my colleagues in the Gulf region, they don't recommend it for weight reduction. It's an experience at the end. Orlistat, also more than 12 years of age, but it will cause diarrhea. Patients usually, they don't like it, especially if they go to school, because they have to go frequently to the toilet. We can use a special thing like leptin injection if diagnosis is the leptin deficiency. Growth hormone can be given for Prader-Willi syndrome in the beginning, before the fat. It will help because it will reduce the fat accumulation and will increase the lean body mass. Okay. So we reached the bariatric surgery. I'm not a surgeon, but bariatric surgery offered if everything is failed and there is a complication of the patients. I have only one case did in children. I saw her here in Bahrain, bariatric surgery. Others we try with lifestyle modification or medication. And it should be done if the patient pubertal, 10 or 4 or 5 stage of puberty, BMI 40 or 35 with complication. If there is comorbidities, just make sure psychological stability of the family and the child, and to be done in, with expert surgeon in a good center. We shouldn't do it in pre-adolescent children, pregnant or breastfeeding adolescent, those planning to become pregnant within 2 years of surgery, or those who not master the principle of healthy diet and activity habits. That's why it should be go for psychiatric evaluation before going to the bariatric surgery. Those who has unresolved substance abuse, eating disorder, or any psychiatric disorder. This is the case. She's 13 years old. Her BMI 45.9. Her weight was 125 kg. She underwent sleeve surgery, and she lost 17 kg after 6 weeks. Her BMI became 39.7. This is her picture before and after. I think I finish. If you like, there are so many international guidelines. The latest is nice. It is in 2025, but you can find Italian and the Australian one, and for your reference if you like to. And I use it in my presentations. And thank you. Finish.
Thank you, Dr. Khadija, for this informative lecture. My question, could the personalized gut microbiome intervention be the key for the long-term management for obesity in order to have an early childhood intervention?
Yes.
And to raise the awareness of the parents about the microbiome, the good bacteria in the gut?
It could be. There are so many studies of it, يعني, it's recommended. That's why also they, many times, they compared who has breastfeeding or who doesn't have a breastfeeding for this microbiome. But I don't know exactly, يعني, I'm just reading these things. It is very important. And a healthy microbiome can be affected, can play a role in that. Yes. Any question?
And for the microbiome, although we know what kind of bacteria are more associated with promoting weight gain and which ones are associated with promoting weight loss, we still don't know how to modify it. If you give somebody, for example, probiotics of certain types, they're quickly destroyed. in the digestive system. So still studies are ongoing on how to modify, even if we know what is to improve weight, what is to modify. While healthy lifestyle, breastfeeding, 5 fruits and vegetables are known, fermented foods are known, so still we don't know how to modify it effectively. It would be, of course, something big in the future, even before pharma. So now we've completed the initial part of the program, and we move to the sponsored symposium with our dear colleague, Dr. Wiam Hussain. He is the president of the Gulf Association of Endocrinologists and Diabetologists, senior consultant endocrinology and diabetes president at the Joslin Diabetes Center, chairman of BEDER conference, and we congratulate you in a very successful yet 7th BEDER conference. He will talk to us today about unveiling the power of Mounjaro or tirzepatide for both type 2 diabetes and weight management. Thank you, Dr. Wiam. So Dr. Wiam, before tirzepatide, people were shy to come to clinic for weight management. After tirzepatide, they come and say, I'm here for tirzepatide. Have you seen this experience?
Every day.
They're more encouraged because we've talked earlier about stigma, we've talked about the mental aspect, etc. And for people to find that it's not their mistake, that they could do lifestyle modification and exercise and not lose much, and there's a tool that can help them with our guidance. So it has really encouraged a lot of people to benefit. There is a question here, Dr. Samarrai.
Thank you very much, Dr. Wiam, for this comprehensive talk about Mounjaro, which is the حديث الساعة هذه الأيام. Everybody is talking about Mounjaro. There was, you mentioned that the half-life is 5 days, right? The half-life 5 days. I don't know whether you're hearing me. So, it is given once weekly, right? So you have a gap of 2 days. Do you think they might increase their food, during this, and you will lose all the benefits in 5 days? If you give them if it is the half-life is 5 days, you should give it every 5 days, not 7 days. So there is a difference of 2 days in between, The recommended is once weekly. The half-life is 5 days. So there's 2 days. Why not every 5 days?
Well, if you look at all the medicines, when you look at the half-life, we do not actually stick to the half-life in terms of dosing. You can take an example of semaglutide. It's the same thing. You can look at the liraglutide. It's not 24 hours. It's less. So there is some still effect, but again, the level of the hormone starts to taper off at the last 2 days. And actually, you can see it in clinical practice. They tell you, I started to feel hungry in the last day, the day before. But it's not so significant, and there is an element of adherence and cost and convenience to the patient to do it once a week. And remembers, if you do it every 5 days, you get confused what day is next. But if you do it in the same day, it's easier. So I think it's multifactorial why it was chosen to be 7 days.
Okay, one more question, please, about the... You've mentioned that it might be useful in those who are on alcohol addiction, right? Or beer overuse. They get deterred from using the beer, this and that. Is there anything related to substance abuse, which is, I think, is more of a generalized, dependence issue,
okay,
more than of an alcohol and this and that? If there is anything like that, would be good. These people are struggling in. Getting out of the addiction cycle.
First of all, I want to make it very clear. It is not indicated for this.
Yeah, I know.
There is no approval.
Yeah.
Okay, I just want to make it very clear.
Sure.
What I told you is that it was really an observation, and I saw it in the clinic frequently. And I'm sorry, there were a lot of them Irish and Scottish. And they enjoy the weekend drinking. And then
Sure.
they became and started telling me, we stopped drinking, or we just drink small amount.
That's a great
So I
news.
digged into it, and there was evidence, actually,
That's
published data about reduction in alcohol.
Okay.
Now, in terms of substance abuse, I haven't seen it in my clinic. I did not come across data or publication that addresses that. But I can tell you that even the craving of chocolate, you know how people are focused on having a chocolate every day because it keeps them happy, the dopamine surge, they stop that. So it's actually many habits that relates to craving,
Okay.
but I cannot specify the
Thank you very much.
substance abuse.
Thank you very much. I know we are concluding that meeting almost like that. I mean, it's a suggestion that we need to see people who are interested in exercise medicine, in addition to the pharma and, and sleep medicine as well, and the nutritionist on top of that. I mean, all these, it's a holistic approach to obesity rather than tackling how to stop the food, how to, do the medicines and this and that. So I think for a holistic approach in the next, inshallah, meetings, we need to see people who are interested in exercise medicine, more details, not just saying go and exercise, and thank you very much, wallahi, for that meeting. I really enjoyed it. Thank you very much.
Inshallah. Thank you. Yes.
Good afternoon, doctor. That was an excellent speech. My question here would be what we have seen in clinical practices, there is this odd patient who just who budgets to lose that weight. I mean, usually you see a pretty good weight loss, say at 12 weeks, say about at least 4 to 5 kilos. But here you see this odd patient who just don't lose that weight. Is there a reason for that, or is there a way we can tell, okay, this patient I give this medicine, he's going to lose weight, and that patient is not going to lose weight? Is there something?
Okay. First of all, you cannot predict. And I try to see any equation or any clue that tells me this person will respond or not from the beginning. And there isn't. There isn't. You try it and see how they affect, and then you'll see they are good responders. And you can tell that they are good responders in the first 2 months. With the 2.5 and 5, you can see the effect there. And again, those who are not a good responder, I sometimes look for secondary causes, something that makes them not lose the weight, sleep pattern, use of medications, steroids, hypothyroidism, subclinical Cushing syndrome, anything of that sort. But I have to first improve the way they eat. The portions are small, but we need to make sure that the calories are not too much, because you can have a huge amount of calorie in a small amount of food and calorie-dense food. And we need to ensure the 2 types of exercise being done. And most of the time, I gave you numbers up to 96 and 98% will lose 5 to 10%. And that actually, 5 to 10% is good enough to improve many comorbidities. But in this drug, it went beyond that and gave excellent results compared to other conventional therapies that we have.
Thank you, thank you. One more question, doctor. I mean, again, it's a very common question asked by patients. They say, okay, how long do I use this drug, and what happens when I stop? I mean, invariably we see that most patients do gain weight in spite of following a proper diet and exercise program. So is there anything in your experience that you do where how we can make them sustain that weight loss?
This is $1 million question. Every patient asks me the same question every single day. And there is not a right or wrong answer to it. You tailor it to the patient. I'll give you an example. You have a very badly uncontrolled diabetic. And when you give him a drug that lowers it by 2.6, why should he stop it? It's once a week. It's not a daily injection. It's not insulin that may increase hypoglycemia and weight gain. So in diabetics, you can take it for life. And in obese people, I always look beyond what type of obesity. If it's genetic, if a person said, I was always chubby, I was always heavy in high school, and this is genetic obesity, and genetic obesity is very common. Those people have a chronic condition. It's just similar to hypertension and hyperlipidemia and diabetes. You cannot say, oops, yes, you did well, that's it, stop. No. So I don't stop on those people. Now, what can we do to those people who had a transient increase? I had 2 babies in a row, I gained 10 kilos, but I was always 10, and I want to go back. So it was short duration of weight gain, or took a course of steroids, and then I stopped it, I gained 10 kilos. Those people, you can taper the dose slowly and maintain with a good lifestyle. But there is no right and wrong. You can continue forever. The safety is this drug to be used forever.
Thank you.
The last question.
Thank you, Dr. Ram, for the nice and elegant talk and the clarification for the benefits of Mongaro regarding obesity and if it's combined with diabetes. And the same question for the how long patient can use, especially if he takes the biggest dose, 15 mg, and his weight is stopped to be reduced. So you advise to let him do the lifestyle, the diet, or he can continue again the 15 dose monthly.
So somebody who's on 15 and stops to lose plateau, do you stop or do you continue?
Okay, if you need to continue weight loss and you still did not reach your goal that you and your patient have decided, and you have reached 15 milligram, you can do a couple of things. One is that you can intensify the exercise, same duration, half an hour, that's fine, but make it more intense. You can improve the quality of the food, cut down the calories further. You can add, we have another drug now, Contrave, available in the Bahrain. You can add it, and people are adding both drugs to help to further weight loss. So those are the options you can do. But again, sometimes the goal of the patient is not realistic. And I asked them, why do you want to go to 50? Because before marriage, 20 years ago, I was 50. That's not realistic. No, I'll say I'll stop at 25 BMI, which is good enough. Even 26 and 27 is fine. So it has to be a realistic goal of the weight loss.
How many combination we can use for weight loss?
How many combination?
As a combination for weight loss, you say we can add one more medicine. How many medicine is allowed to be used for as a combination medicine?
Can you combine for weight loss? How many can you combine?
In terms of weight loss, there is no set number of combination. You can combine. The same we do with diabetes. How many drugs categories we can combine in diabetes? All of them. 1, 2, 3, 4, 5, 6. All of them.
Different mechanisms.
For weight loss, we don't have. We have the Contrave, and we have the GLPs and GLP and GIP. That's the only thing we have. However, I have patients who go to the States and bring with them phentermine. And we use phentermine in small doses. And it's coming to the Gulf area as a combination. So we can add.
And if there is herbal medicine like some drugs in the market made of plants origin, like the psyllium husk, some patient is using to prevent hunger, to help them to control their food. We can add this with Mongaro.
For appetite suppression, like herbal remedies.
I mean, you need studies on those herbal medicine. I'm not sure we have enough. There is only the fiber that is used, the fiber gel that is used in the States. I forgot the name of it, but it's coming also, which gives you the feeling of fullness. But it's not as effective. You're talking about 3 to 5% weight loss. And again, you can do all of them together. You can combine them all. And you know what? If you ask bariatric surgeon, they do both. They do the surgery and they give them Mounjaro. So you can combine whatever, surgery or medicine, medical, and multiple medicine.
Thank you.
big thank you to Dr. Wiam. We understand that he has clinic to go to, but we can take additional questions later to myself directly after the meeting. And Noel, where will be the lunch served? Before lunch, we will have you all come for a group photo, though. So we'll just present you the certificate of appreciation, Dr. Wiam, and then take a group photo. So can we have you all come here for a group photo? We like big group photos. So everybody squeeze in into a nice big photo together.
We would like to thank Lily for this event, who are supporting Bahrain Diabetes Society. And we'll see you, inshallah, in the third session. Thanks, Lily, a lot for your support.
No.